Okay, we'll start. It's 2 o'clock. Good afternoon. I'd like to welcome everybody. Okay. Please, as a reminder, please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of companions attending. Please use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and end of the pep talk, so please show your face in the video during the picture taking. As another reminder is to take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. The link is already in the chat box. Okay, so this is the sample of certificate that you will be receiving if you get a perfect score. Another reminder, a mentee is entitled to one voucher for a ROJoson telemedical consultation if they have 50 OLETE certificates. So this is a picture of the voucher. So let's now have a group picture taking. Please show your beautiful faces. Okay. Ready? Ready, Chris? Emmy, would you like to show your face, Emmy? Alba, Chris. Okay. 1, 2, 3. Okay. Right. Okay. Okay, let's have another picture taking and then si Emily. Okay. 1, 2, 1, 2, 3. Okay. No, I didn't. Ulitin nga natin. 1, 1, 2, 3. Okay. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021 last year. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Thyroid Cancer, Part 2. This is part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of thyroid cancer. So last week, we tackled this part 1. This time, we will be tackling part 2, which will include treatment, surveillance, prognosis, and palliative and hospice care for thyroid cancer patients. Some definition of terms in the title and the limitation of the coverage of my talk. First word is fundamentals. This is used to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. Generalities to mean general statement of information, not covering the specifics and not too detailed. Medical management means diagnosis and treatment of thyroid cancer by the physicians. Let's start with treatment for thyroid cancer. So after the diagnosis and after formulating the pre-treatment diagnosis, so the diagnosis before the treatment, which will include the extent of the thyroid cancer, the first thing to do before considering and comparing the options of the treatment methods or modalities is to spell out the specific objective or goal of treatment. This is whether curative or palliative. When you say curative goal, it means try to eradicate all visible or known tumors or cancers entirely or all of them, preventing the recurrence or spread of the primary cancer. And when you say palliative goal, this is just relieving the symptoms if we have accepted that all reasonable curative approaches has been exhausted or it's not practical to do so anymore. At the time of the treatment, a patient may present with a cancer stage in which the goal is at best palliative only, relieving the symptoms. These are usually the patients with advanced cancers. Example here. So this is an example of anaplastic carcinoma, okay, which is fast growing, causing compression of the airway and also the gastrointestinal tract or the esophagus. Okay, so here the goal for treatment is just palliation. Okay, so the other type of cancers that can be that will be having the palliative goal are those with advanced papillary, follicular, or medullary cancers. So this is an example of an advanced papillary thyroid cancer, okay, in which the goal would just be palliation. So thus the objective of treatment is primarily dependent on the stage of the cancer at the time of the treatment. For patients presenting with early stage cancers, resectable or operable cancers, the goal is curative, that is eradicating all the tumors and cancers and preventing recurrence and spread of the primary cancers. So these ones are early stage, confined to the thyroid lobe. And this one is also quite early, although there's a lymph node already on the neck, but the goal will still be curative, but because this is still resectable or operable. The stage and staging of cancer describes the extent of a cancer. So there are so many ways of staging cancers in general. You can have such a staging like early stage, advanced stage, localized, regional, distant, localized, early locally advanced, late locally advanced, and metastasized. And then the most popular one is the TNM staging. In the medical world, it's the TNM staging, which is the most popular staging system, which describes the size of the cancer and how far it has grown. So the TNM staging is like this. T stands for the tumor. Okay. So during the evaluation, we answer this question: how large is the primary tumor, the main thyroid tumor? Okay. Then N stands for nodes. So the question being asked is, has the tumor spread to the lymph nodes, to the side of the neck for thyroid cancer? If so, where are they and how many? Okay. M stands for metastases. So T and M. Okay. So the question being asked is, has the cancer spreads to other parts of the body? If so, where and how much? Okay. So TNM staging system. The TNM staging system for different types of cancers are different. No? So for thyroid cancers, the staging is based on the type of the cancer present, whether it's papillary, follicular, anaplastic, or medullary. These are the common types of cancer. Okay, papillary and follicular are the most common. Okay. Then the other basis would be the age of the patient, but this is only confined to papillary and follicular cancers, as we shall see later on. Then, of course, they base it on the track records of the different types of cancer. They gather data from the past and then see what could be a good staging system. So at the moment, the TMM staging for thyroid cancers consists of these four groups. Okay. Papillary follicular thyroid cancer, younger, there's an age factor here, younger than 55 years old. And then another group is papillary and follicular thyroid cancer for those 55 years old and older. And then for medullary and anaplastic. So you can see here the difference among the four. Anaplastic cancer, there's no such thing as stage 1, 2, 3. Automatically, it's stage 4. Okay, poor prognosis, advanced. Okay. Now for papillary, follicular, medullary, which the prognosis are relatively better than anaplastic, but you still differentiate it in terms of the age. Okay. If the patient is more than or equal to 55 years old, you still have the stage 1, 2, 3, 4. 1, 2, 3, 4. But for those who are younger than 55 years old, you only have stage 1 and 2. Okay, so no more 3 and 4. Okay, as mentioned, anaplastic cancer is automatically stage 4, regardless of the size of the tumor, the original size, the location, and the presence or absence of metastasis. Okay. Now for papillary and follicular cancers, aged younger than 55 and older than 55. As I said, there's a difference. Okay. Why is this so? Because it has been shown that younger people who have a very, very low likelihood of dying from the differentiated, when you say differentiated cancers, this referred to these two, papillary and follicular. Okay. So the TNM stage groupings for these cancers take this fact into account. That's why people younger than 55 years old, okay, will just have stage 1 and 2. Okay. Those which have distant metastasis is not considered stage 4, but stage 2. Usually when you have distant metastasis, it's stage 4. But for this group of patients, papillary and follicular cancer, and then younger than 55 years old, so the presence of distant metastasis just make it stage 2. Okay. So here is a summary of the what I just mentioned, less than 55. So you only have stage 1 and stage 2. For the more than 55 years old, and okay, 55 years old and older, okay, you have 1, 2, 3, 4 already. Okay, T1 means the size of the tumor is less than 2 centimeters. T2 means the tumor is 2 to 4 centimeters, and then T4, it's more than 4 centimeters in size, and then T4, it's more extensive. Let's say 5 or 6 or 7. Okay, N stands for lymph nodes, N stands for metastasis. So in this particular patient with papillary follicular carcinoma, he is more than 55 years old. Okay, so most likely this is more than, it could be T3 or T4. Okay, if you try to measure it, but because of the from the look of the tumor, there's a skin changes already. Okay, most likely it's T4. So T4 here, and then let's say there's a non-node or there's a node. No, and then if there's a distant metastasis, it becomes 4B. If there's none, it's still 4A. Okay. There are a lot of cancer treatment being advocated, mainstream ones and then the non-mainstream ones. Mainstream ones are those accepted by or being promoted by majority of the physician cancer specialists, and this is also called conventional or standard treatment with well-documented evidences for effectiveness, but in various degrees. The non-mainstream ones are usually they're called alternative medicine. So with the health claims that are not usually meeting the evidence-based standards. Okay. Alternative medicine is defined loosely as a set of products, practices, and theories that are believed or perceived by their users to have the healing effect of the medicine, but whose effectiveness has not been established by scientific methods. Okay. And the commonly used alternative medicine used for cancer in general, this can also be used for thyroid, are the herbs and herbal medicine, special diet, supplements including vitamins, acupuncture, lifestyle medicine without using medicine, but there's a healthy eating, healthy physical activity, and healthy behaviors. Okay. So another way of categorizing the alternative medicine, natural products, these are the herbs, no? Okay. And then the mind-body medicine practice, example is meditation, manipulative practices like the chiropractic therapy, and then the body-based practices like massage. In the Philippines, there are no data on the use of alternative medicine, but I suppose there are, okay? So, but in the USA, okay, in two reports, 2013 and 2018, as high as 74% and 80% of the Americans are using alternative medicine in the management of thyroid cancers. But majority are using it for symptom relief rather than treating as a treatment for the cancer itself. Only 30% are using it for treatment of the cancer. So a word of caution on the use of alternative medicine for thyroid cancer. Okay. Delaying surgery, radiation, and chemotherapy or other traditional treatment by using alternative therapy can allow the cancer to grow and spread to other parts of the body, okay, especially if the alternative medicine is not effective. So you just keep on delaying and allowing the cancer to grow. Evidence show that people who use alternative medicine or therapies in place of standard cancer treatments have a higher death rate. Okay. So these are in this part on this column, it just shows that they have higher death rate for breast and colorectal cancer, but there's no study on the thyroid cancers. Okay. But most likely it will have the same outcome. So if you keep on treating the thyroid cancer with alternative medicine, now you let it grow to the point that it's not operable anymore. So we are contributing to the higher death rate, higher incomplete or unsuccessful treatment. Now, as to the mainstream modalities of treatment of thyroid cancer, usually the most common, the primary treatment is surgery or operation or cutting, hormonal therapy as an adjunct, radiotherapy and radioactive iodine therapy, chemotherapy, immunotherapy, targeted therapy. Okay. Each one of these will have its own indications. The mainstream therapies can be divided into two, classified into localized and systemic. Okay. Localized treatment means those that are directed to the specific area, such as the thyroid tumor and the neck tumor. So they include surgery and radiotherapy. For systemic therapy, that means the drugs or anything that is being given to the patients is spread throughout the whole body to treat the thyroid cancer wherever they may be. So this includes radioactive iodine therapy, chemotherapy, hormonal therapy, targeted therapy, and immunotherapy. So in the thyroid cancer, it can be localized treatment only, especially for the early stage, so surgery or radiotherapy, systemic therapy only, radioactive iodine therapy, hormonal chemotherapy, and It could be also be a combination of localized and systemic therapy. So, but it all depends on the stage and the situation of the patients. Any cancer treatment can be used as a primary treatment. But the most common primary treatment for thyroid cancer is surgery up to now. Okay, surgery, especially those in the operable, which can be operated. Okay, operable stage. Other combinations of treatment are done depending on the anatomic stage. So if stage 4, you might have to add more. Prognostic stage, those with poorer prognosis, and other factors like the track records of effectiveness. The general guidelines in the treatment of thyroid cancer, we classify them into 2 operable thyroid cancers, which can be operated. Okay, so the initial treatment is surgery, operation. Okay, these usually include total or subtotal, depending on the extent of on the size and extent of the tumor. If it involves both sides, left and right lobe, then usually total. If it involves only one lobe, a subtotal can be done. And then there could also be a neck dissection if there are lymph nodes on the side of the neck. Now, after surgery, usually you can give hormonal therapy in terms of levothyroxine. This is a thyroid hormone. There are 2 uses for this. Replacement, if patient has undergone total, meaning the whole thyroid gland has been removed, so he or she now is in the hypothyroid stage, so you have to replace the hormones. Or it can be used for suppressive therapy to prevent the recurrence of the thyroid cancer. Then the other type of therapy that is being used commonly for operable thyroid cancer is the radioactive iodine, in which the patient is asked to drink the radioactive iodine, and then the effect will be on the area where the tumor is located in the body. So this is an illustration of the operation. So if only one lobe is involved here, so we can do thyroid lobectomy only, okay, one side. If there's a let's say there is okay, if 2 lobes are involved with tumors, then we do the total. Okay, so now here subtotal can be done for if there are 2, let's say there are 2 nodules here that thyroid cancer, then you do a subtotal up to the other side, but with a good margin. But in some cases, even with a solitary thyroid nodule on one side, a lot of physicians are still doing subtotal. They extend it to the other side. Okay. So in the presence of lymph nodes, then we do the neck dissection. It varies on the extent of the nodal involvement. It could be a radical neck dissection, which is very extensive, or modified radical neck extension, or the limited neck dissection. So additional treatment, let's say after the operation, after the operation was done, so you can have other treatment. Okay, hormonal therapy is the usual can be done. Okay, as I said, it can be used to replace as well as to suppress to prevent the recurrence. Then radioactive iodine therapy after the operation. Again, it's used to ablate the remaining thyroid tissues and the thyroid cancer if they're still remaining after surgery, or to run after the metastatic thyroid cancers which cannot be operated on. For the inoperable thyroid cancers, okay, so these are the patients usually for palliation only. So radiation therapy and chemotherapy are two options that the physician can consider. So the options are listed down here in terms of treatment. Okay. And then the doctor usually have to give the BRCA, data on benefit, risk, cost, availability. And then after the data are given, the patient is asked what he or she prefers. So example here of the data given, greatest survival rate for option 1, least survival rate for option 3. Okay, in between, okay, option 2 is less than 1 but more than 3. Okay. Example, in a situation in which the risks are all acceptable and the cost differential cost 5,000 for option 1, 6,000 and 3,000 for option 3. So assuming that all the treatment modalities or options for treatment are all available. So which is the best option to choose? I would suppose you put emphasis more on the benefit, okay, compared to the others here. So the greatest survival will be the best choice. No? And then the price is 5,000 compared to 6,000. Okay, so you choose option 1. Another scenario, another patient, okay, or another data that will be given to a patient. Option 1 has a survival rate the same as option 2, so they are the same. But option 3, the least survival rate. Okay, so right away, if you have to choose which one, you don't choose number 3 because it has the least. So you're now talking about either 1 or 2. But then you look at the complications. If there are more complications with option 1, then you would rather take option 2 because it has less complications. Another data that will be given to us or to you will be option 1 has the lowest recurrence rate, then option 3, the highest recurrence rate. So again, putting emphasis on the benefit, priority. Okay, so you would choose option 1 because it has the lowest recurrence rate. But the data given to you is that it has a very, very high risk for complications, 5+. Okay, so you might think otherwise, so you might go for option 2 because the risk here is only 2+. Okay. Surveillance for thyroid cancer. Surveillance for thyroid cancer will consist of monitoring for recurrence after all the evident cancers have been eradicated. This is after a curative treatment. Or it can be done to monitor the progression or regression after a palliative treatment. Okay. So the questions here is by whom, how long, how often, and what methods. By whom first? Usually the oncologist because we're treating with cancer. Okay, but you have to, sometimes you can have the family physician to assist in the monitoring. Okay. And the parameters that you use to choose which physicians will be monitoring the thyroid cancer will be the competence, expertise, professionalism, holistic, compassionate care, cost, availability, and convenience. So these are the different types of, when you say oncologists, there are so many types. You have surgical oncologists, which consists of head and neck surgeons for thyroid cancer. Okay. And then this include at the moment, there are two types of head and neck surgeons. You have the general surgeons and then the ENT surgeons. Okay. And then medical oncologists, these are the people who don't operate but give you medicine like chemotherapy or other types of treatment, targeted, etc. But since we're talking about thyroid, and since endocrinologists are also treating thyroid patients, they can also be chosen to take care of the thyroid cancer. Nuclear medicine specialists are those which gave the RAI, radioactive iodine. Radiation oncologists are those which give the external beam radiation, the external radiation, radiotherapy. Okay. As I said, you can choose one or more as indicated, whom you prefer based on these parameters. How long? Again, depends. It depends on the type of the surgery treatment done. For those with curative treatment goal, it's a lifetime monitoring as all the cancers have the potential to recur even after a long period of time. Then for those with palliative goal, of course, you want to monitor until if there is progression or if there's regression. And if there is progression, then there's a call to just go for hospice, no more aggressive treatment. And then for the rest, you monitor the patients until the end of life. Okay, if there's no more, the treatment has not been successful. So how often? Again, two situations. You monitor for the immediate results of the treatment, And then you also monitor for the recurrence after a curative treatment. So when you monitor for the results of the treatment, you're actually monitoring the side effects and complications of the treatment done. Example, after surgery, you monitor for the complications in terms of loss, hoarseness of voice, then hypocalcemia, okay, etc., wound infection, etc. Okay. Then you also monitor the response to treatment. Example, you're giving hormonal therapy. Usually, you wait for about 2 to 3 months to see the effect. Radioactive iodine, you complete the course. Okay. So usually, the radioactive iodine usually given within 2 to 3 days, okay, in a hospital setting, but you wait for the result about 2 to 3 months after. Chemotherapy, the same, okay. So let's say every 3 weeks, the cycles every 3 weeks, but for 6 cycles, then you monitor the results after probably after 3 cycles, you monitor for the results, and it could be 6 months thereafter, you monitor for the results. Okay. So the duration of monitoring will be depending on the type and duration of the treatment, the recuperation time, expected response, such as 2 to 3 months for hormonal therapy, RAI, radiation, chemo. Okay. But the range is usually daily. As I said, after an operation, you have to monitor it daily to every month to or an average of 6 months. And it could be, we're talking about monitoring of the results. Now it's different from monitoring for recurrence. So it's average of 6 months. But when you monitor for recurrence, okay, it will be longer. No? So it depends on the type of cancer, treatment done, usual prognosis, time of treatment, whether it's soon after or long after, and then the mindset and personality of the patients, etc. As a general guideline, that the monitoring for recurrence after a curative treatment will be more often for those with higher risk for recurrence, such as an aggressive type of cancer. Example, if you have done you were able to remove a small anaplastic carcinoma, the monitoring for recurrence will be monthly probably, okay, because it's very aggressive. The other guideline will be early post-treatment, say 1 to 2 years when the recurrence usually appear. Okay. And then the other factor to consider will be anxious patients. There's a lot of probably nervous patients, okay, who need frequent psychological support from the physicians. Okay. Now, what methods of monitoring? There are 2 types: symptom sign-directed surveillance approach and regular screening with laboratory tests. So the first one, symptom-directed, we just rely on the symptoms of the patient and the physical signs, meaning the examination findings of the physician. And whatever, if everything's normal, then you don't need to go for instrumental laboratory diagnostic tests. But if there are things that have been discovered during the interview for the symptoms and the physical exam for the signs, then it will dictate what laboratory diagnostic test to be done. Whereas the other method, regular screening using laboratory procedures. So basically, this is a battery of tests being done on the possible site of recurrence, okay, even in the absence of signs and symptoms. And the usual tests that are being done that probably most of you will be aware of if you have thyroid cancer. Okay, so ultrasound of the neck, total body RAI scan, and PETs. Lately, PET scan is becoming popular. Okay, so these are the 3 most common tests being done to monitor the recurrence. So the options are given. So 2 options is symptom directed and battery of test directed. So you compare the 2. Okay. So you compare the 2 on 3 aspects. No? Okay. Benefit in terms of early detection, benefit in terms of survival, benefit in terms of quality of life. No? So if you use, okay, let's see. Example, if option 1 is symptom directed, option 2 is battery of tests. Okay, so the advantage of the battery of tests, because you do a lot of tests, you have early detection. That's why it's 3+. And then symptom directed, you can still detect the recurrence of the thyroid cancer early, but it's not as high as the battery of tests. Okay. Now, in terms of survival, example, you are given data that whether you do symptom-directed or battery of tests, the survival is the same. Okay, so these are the data given to you. Okay, so the risk here will be you have pain, a lot of tests are being done. Okay, and then the other parameter that you use would be the quality of life, supposing that with symptom-directed, now you were able to detect it late, but the survival, the months or years of suffering is just less before you die. Then the quality of life will be better compared to the other one. You do a lot of tests, you're able to discover it early, but studies, if the studies have shown that the patients undergoing symptom-directed and battery of tests die at the same time, so you can say that the quality of life for those with the battery of tests will be poorer. Okay, and then you have the problem of false positive results under the battery of tests, and then of course the expense. It's very expensive. Now, prognosis. Prognosis just means estimating how the cancer will go for you, the likely course of the cancer with or without treatment, and then the chances of recovery from the cancer, chances of response to treatment, okay, whether it's for cure, and then you monitor for the recurrence. Usually you use the estimation of 5 to 10 years survival rate or median survival rate. So the prognosis also depends on the type of cancer. As I said, anaplastic has the poorest prognosis. The stage of the cancer, stage 1 is better than stage 2. Okay. Inherent biologic behavior of cancer. Some are fast-growing, slow-growing, with or without comorbidities in a particular patient, and then the gravity, and then of course, based on the track records of the cancer. These are the information that you get from research studies. So, based on track records, we usually use the studies on 5 to 10 year survival rate and the median survival. Okay, it can be by stage, and then it can also be the data can be with or without treatment. The 5-year or 10-year survival rate just means the percentage of patients who are alive 5 years or 10 years after they were diagnosed. Okay. Example, this table shows that for the different types of cancer, papillary, follicular, medullary, anaplastic carcinoma, so data on the 5-year survival rate. Okay, so you can see that for anaplastic carcinoma, as we mentioned, it's automatically stage 4. So in 5 years, only 7% are still alive. So it has the worst prognosis. Okay. Now for the papillary and follicular, if they are in the stage 1 and 2, practically 100% still alive. Okay, good prognosis. But when the stage becomes stage 3, okay, then stage 4, the data will now change. Now, okay, so it will be progressively worsening. Now, but you can see that even with stage 4 for papillary and follicular, you still have about 50% are still alive. Okay, relatively good prognosis. No? So to repeat, papillary cancer has the best prognosis. The worst is anaplastic carcinoma. Another parameter that we use to determine the prognosis will be the median survival of cancer. This is defined as the length of time from either the date of the diagnosis and the treatment for a cancer that half of the patients diagnosed with the disease are still alive. Okay, so it's usually in terms of months, but some would choose it in terms of years. Okay, and the median survival can be calculated based on these factors: those with treatment, those without treatment, and then based on the stage and based on the type of metastasis. Now, in the thyroid cancer, there are only a few data on median survival because most of them have a good prognosis. Okay, they usually survive for a long time. And medium survival usually used for those which have a poor prognosis. Okay. So just to summarize, this is another data, 5-year survival rate of thyroid cancer, papillary close to 100% for localized, around 80% for metastasis, even with stage 4 you still have 80%. Follicular close to 100% for localized and around 63% for metastasized, so a little lower. Medullary, okay, so 40% for the metastasis. And then for anaplastic, even for localized, you only have 31%, and then only 4% for or those with metastasis. Palliative and hospice care for thyroid cancers. There are two terms that one will encounter in the medical management of thyroid cancer, in which Filipino doctors or lay people are not familiar with, and doctors are not explaining this to the patient. Okay, so you have the palliative care and the hospice care. Palliative and hospice cares are being used in advanced cancer patients, even thyroid cancer patients who have little or no prospect of cure and who are expected to die, or for whom the primary goal is to optimize the quality of the remaining life on Earth. Both palliative and hospice care provide comfort for the advanced cancer patients, both in terms of physical, mental, and spiritual well-being. Palliative care can begin at the diagnosis, and at the same time as the treatment, it consists of active anti-cancer treatment. Okay? But for the hospice, usually it begins after somebody has declared that no more hope for cure, just don't do anti-cancer treatment anymore. Okay, just do supportive management, just to make the suffering less before a patient dies. Okay. So the process here, advanced cancer. So the goal is palliative care, palliative goal, and then you start with the palliative care, and then if this is not, you reach a point that you have declared that the person is not going to survive the cancer already, then you go for the hospice care. Summary takeaway, I have discussed part 2 here, treatment, surveillance, prognosis, palliative, and hospice care for thyroid cancer. Okay. Takeaway in relation to patient empowerment, be always in touch with reliable medical information on fundamentals and generalities in medical management of thyroid cancer. Knowledge is power, it gives power. Use the 4 Ks of patient empowerment, kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of thyroid cancer. So with that, I end my lecture. Okay, I hope I have empowered you to have a better understanding on the fundamentals and generalities of the medical management of thyroid cancer. And then before we go to the question and answer portion, reminder, the OLETE, okay, and then a voucher that will given to you. We're now on the 33rd PEP talk. Okay, so there are about 33 vouchers that will be OLETE certificates that can be given away. Okay, if you pass. Okay. Okay, so let's now have a group picture taking before we go for the open forum. Okay. Okay. One, ready? Okay. 1, 2, 1, 2, 3. Okay. Okay, the floor is now open for questions, interactions, okay. Anything that you want to ask. Okay. Are there questions already, Matt? Okay, while waiting, wala pa? While waiting, let me just update you on the Olete. Okay, so we're now on the 33rd pep talk as of today. Okay. So the last one was fever and paracetamol, myth and tips. Okay, today it's fundamentals and generalities in medical management of thyroid cancer part 2. Okay, and then so I have posted this in the group page now in the pep talk. Okay, you just take a look. Okay, so just know where you stand, but check the accuracy of my data. Okay, because it's so difficult to keep track of all your records. Now I might miss somebody or baka mali. Now, so you just tell me. No, okay. So and then this is also a guide for you kasi iba inuulit. No, tapos na no, sayang ang time. No, okay. And then, okay. Wala pang tanong kasi, no? Okay. So I'd like to announce that, anyway, everybody knows my birthday naman, di ba? Makikita niyo sa Facebook, di ba? Okay. So January 31, that's about 2 to 3 days ago, to go. Okay. And then February 1 is the Chinese New Year. Okay, so I don't usually crave for gift on these special occasions, no? Kasi minimalist ako di ba? Okay, I want to go die empty. Wala na akong dadalhin sa ano. Okay. So, but I gladly accept gift kung meron, okay lang, no problem. But this year will be an exception. So I crave for a list of 60 promoters and advocates of breast self-exam among my ROJoson Breast Cancer Crusaders. So I look forward to this list. Just announcing this just to encourage all of you to give me gift in terms of 60 promoters, no? Okay, breast self-exam. So the other day I received already a beautiful gift from Lorly Ricaforte. So she has submitted 5 names. Okay, 1, 2, 3, 4, 5, and then with the preliminary video. Okay, and then Mabel also has conducted a Zoom meeting for the breast self-exam members. No? So I look forward to more gift on this one. Okay. So any questions or any pledges for my gift? Ladies? Andiyan mo si ladies? Okay. Okay. No questions?
Walang questions.
Okay. So the people who wants to share their experience, Aida, you want to share your experience? Aida, Antonio? Nawala si Aida. Is Aida there?
Nakamute po siya.
Okay. So Aida, actually you heard about her sharing last December. No? She has thyroid cancer, papillary siya with neck node. No? With neck node. So I did actually she went to 2 or 3 surgeons. No? Okay. So the last surgeons was me. So I removed the thyroid cancer and then the neck node, so neck dissection. So she's now on her more than 30 years in remission. No?
Wow.
So you can see that papillary thyroid cancer has a very, very good prognosis. No? Okay. Okay. It's still, you can live a normal lifespan. In other words, if you have papillary cancer, no? Okay. Then compared to breast cancer, compared to other types of cancer. Okay. Okay. And then who else has a thyroid problem dito? Walang may thyroid cancer na, no? Okay. Oh, Aida, you're there already. Would you like to share your experience to the group?
Ah, ano po? 33 years in remission.
Okay, 33 years.
33 years in remission.
Okay.
Okay.
So, did you undergo RAI therapy?
Ano po ulit, Doc?
Did you undergo RAI, radioactive iodine therapy?
Hindi po. Radioactive iodine. Surgery lang po sa inyo.
Okay, so iba-iba. As I said, we give the patient the options. No? To other doctors, they will give RAI. No? Okay.
Ang natatandaan ko po sabi sa inyo, surgery is enough. No
Yeah.
need for radioactive iodine.
Yeah.
And then, yung po sa ano to? TNM.
Yeah. TNM.
Halimbawa po yun sa thyroid and then na-operahan nga po. Yung sa akin meron nga pong umakyat, parang na-metastasize. Lymph nodes po ang tawag doon.
Yeah, N.
Yung
So,
pong parang, yun nga, parang ubas na,
yeah.
if I remember right, nakita ko po yung inalis nyo, mga 6 to 7 pieces na parang size po ng mais.
Yeah.
Isang butil ng mais.
Tawag,
So bakit po siya dikit-dikit? parang siyang ganun yung tubo.
ask God. Di ko- Okay, bakit tikit-tikit? Okay, wala akong, I cannot control that. No? Okay.
Okay po.
Basta
And then po, ang natandaan ko dito sabi nyo noon, matyaga nyo pong in-scrape yung mga lymph nodes kasi po pag ano daw, pag yung madadamage po kasi yung muscle. Okay?
Yeah.
Kundi pag nadali po yung muscle, it will be a lifetime na mamamanhit. Kaya nakita ko po yung tiyaga nyo po. Ang term nyo po nun, kinayod, scrape, okay? Taking care of the muscles. So,
Yeah.
Doc, yung po tabi-tabi, yun po yung nakita kong naalagaan nyo po. Ano po? So, grateful kasi nga po doon sa katiyagaan nyo na scrape and then no recurrence up to now. Okay. So, ano po yung posibleng katabi ng mga thyroid na kung if ever metastasize ay mahirap pong madamage. Kaya po minsan pag nakakita ko ng cancer patient na nabubutasan po dito, naawa ako. Yung sa leeg.
Yeah, usually,
And then,
yung thyroid cancer, no, mag-umpisa sa isang bukol sa thyroid gland, no? So, if you leave it alone, no, okay, two possible scenarios, no, it can keep on growing, no, okay, and then yung iba medyo mabagal lang, na kasi kung depende sa type, no, pero pag if it's pag minalas yung isang pasyente, it turned out to be tawag doon, anaplastic carcinoma, mabilis yon, di ba? Mabilis ang takbo. So pag let's say, pinabayaan mo lang, just keep on waiting, then lalaki to the point na kakainin niya yung yung windpipe mo. Yung windpipe, no? Kaya pag kinain na yon, mahirap na tanggalin as a surgeon, kami mahirap na tanggalin, no? Unless we will sacrifice your windpipe, no? Kaya sinasabi mo may tubo, no? Yung iba, baka hindi na matanggal, no? So sinasakal kasi, di ba? Kasi diyan daanan ng hangin, di ba? Diyan daanan ng hangin diyan, no? So kung nakaipit doon, hindi makakahinga isang pasyente. No? So usually, nilalagay ng tracheostomy, yung may butas. No? Okay. Ganon. No? Okay. So yung iba naman, yung tinatanong mo yung sa tabi-tabi, aside from the trachea, minsan pati yung esophagus, yung daanan ng pagkain. So tatamaan din yon, didikit doon. No? Ayun, hindi na makakakain ng mga pasyente. No? Ganon. No? But for the, fortunately, yung anaplastic is not so common. No? Okay, fortunately. No? Okay. So mas 80%, 90% are still papillary follicular carcinoma. No? Mas magandang prognosis, mas madaling gamutin. No? Okay. Usually operation is still the best. No? Okay. Okay.
Thank you po, Doc. Every year talaga, very thankful ako.
So yung mga nasa side mo, lymph nodes yun. Ang tawag doon, lymph nodes. No?
Apo.
Okay. So that's why kahit na may usually yung mga, kung sa breast cancer, kung may lymph nodes ka, no, iba ang interpretation nun. Mas pangit ang prognosis. Okay? Kung sa thyroid, kahit na may lymph nodes ka, hindi pumapangit. Pero at least, I mean, it's not, hindi naman talagang wala, it doesn't say wala ka ng pag-asa. Di ba? Ganoon, no? Okay. So, maganda pa rin. Pwede mo lang basta habulin mo lang habulin in the early stage. Okay? Kasi kung may lymph nodes ka at pinabayaan mo rin, dumadami, kakapit dun sa mga blood vessels mo rin, no? Sa big blood vessels. Na kung kumapit na sa big blood vessels, hindi na kaya tanggalin. No? Okay. Okay.
Thank you po, Doc.
Any other questions? None? Nobody wants to, okay. May 1 minute pa tayo to 3 o'clock. I know some of you has thyroid. Not probably 1 or 2 or 3. Okay, 1, 2, 3. 1, 2, 3. Okay, 4. So I was thinking, next week, hindi ko pa hinahanda yung lecture ko. Probably we'll talk about goiter. No? Okay. Para mapasama yung, para isakop na natin yung non-cancer. No? Okay. How to approach it. No? Okay. So I'll be, okay lang, we'll talk about goiter in general. Goiter, ano bang magandang title? Myth and tips. Okay?
Yes, po,
Ayo.
Doc.
Yes, Doc, maganda yon.
Maganda po yung sa goiter kasi pag kala nila agad cancer of the thyroid agad eh.
Sige. Sige, I will prepare a lecture on that. Goiter, myth, and tips. Na? Kasi maraming myth din dyan di ba? So, examples, ang tatanong, well, bawal ba yung kumain ng cauliflower? Mga, di ba? Diba? And then, marami ring myth from the part of the doctors. They do a lot of tests na hindi kailangan. Di ba? Okay. And then tips will be how to diagnose yourself. Okay. When to worry, when not to worry. Di ba? Okay. Okay. Any questions?
Doc, may pahabol na question si Chris. Chris N. Doc, pag may breast cancer ka ba, gaano kalaki probability na magkaka-thyroid cancer ka?
Walang, let's put it this way. Walang studies that show that once you have breast cancer, 90% of chance you're going to have thyroid. Okay. Kasi kung gano'n yung trend, sabihin natin talagang may connection, no? Yung thyroid saka yung breast, no? Wala, no? Okay. So, but in reality, no? Once you have a breast cancer, just look at the reality, the concept of life, no? anything can happen. You can also have another disease in other parts of the body. No? Okay. Hindi lang sa thyroid, no? Baka pwede ka magkaroon din sa uterus mo, sa ovaries, or stomach, no? Ganun. So, iba-iba, no? Okay. So, parang, okay, it reminds me of, anyway, one of our patients who testify, who made a testimony last year, no? Okay, so she has breast cancer and then she had kidney cancer. Okay, that's a possibility, you know. So she survived both, no? Okay. Okay, so what I'm saying, once you have a disease, no, don't just say that you won't have another disease. You can still have another type of disease. Okay, so possibly anything is possible. How do you prevent? I don't know, except for your healthy lifestyle na lang. Okay. That's why importante meron tayong intentional living plan because we don't know what the future will hold. No? So gawin na ninyo lahat ng gusto nyo gawin up to age 70. Para everything is bonus na. No? Okay. Any more? No more questions?
Wala na, Doc, sa chat box.
Okay. Okay, so if none, let's call it a day. So, so we will have goiter, meat and tips next week. No? And then, of course, sige, let's call it a day. Then those who want to stay can stay on. So we'll